And we're live. Cool. Thank you very much, Robin. Thank you very much, Zvi. Welcome to everyone who's joining. Thanks for joining us. So I wanted to, this is the first Less Wrong debate, and I've wanted to have a debate like this for a while. In particular, I've been interested in having Robin and Zvi have a debate ever since I saw them writing various disagreements to each other on the internet on topics like blackmail. Robin's blog, Overcoming Bias, I've been reading for about 10 years, since I was like 13. So I've learned a bunch from that. And also I've seen Robin in various debates, and I've learned, I can't think of a comparable reference class for sort of bullet of Econ 101 knowledge than when I've seen Robin do certain debates. I have occasionally watched, there's a great debate Robin does with a guy who says we're going to colonize space soon on YouTube that I've occasionally watched with friends for fun. And then Zvi's blog, I've been reading for a couple of years, and in terms of effect size, well, I guess you got me to stop using Facebook, which I've definitely learned a lot from that. In particular, yeah, I have not used Facebook for about 9 months, except I broke it to, like I haven't posted and I haven't used a React, except for making the event for this event. So, you know, you should question the incentive you're
throwing it all away just for this.
But yeah, and so I think a lot of people in the current world don't have many opinions, and they're sort of scared to think for themselves in public. But wherever I see sort of Robin and Zvi writing, they're always very much themselves and very much having strong opinions. We're originally going to take this debate on a different topic, but in the current crisis, it seemed like it was something Robin's been writing about for over a month now, about his particular policy proposal, and Zvi had a lot of opinions, and it seemed like a good topic to discuss. So I thought I'd be interested just initially to ask you guys how you're currently dealing with the current crisis and how much it's affecting you. I'm curious, Robin, I don't know, how have the last couple of weeks been for you?
Well, we moved into this condo 2 years ago. So as a professor, I'm still working. I'm just working from home, teaching classes over the internet here. I had a little more warning than most, so managed to stock up. So I'm relatively comfortable. We're mostly anxious about, well, my mother, who seems to want to go to church every few days and hang out with people, and can't be talked out of that. And we have, lots of food that isn't as tasty as the food we could get if we went and got fresh ingredients, and we have to decide whether to be tempted to go out and get fresh ingredients or make sure to stay home, and whether we should not let the maid come and let it get dirty or that sort of thing. But otherwise, doing pretty well.
Yeah, it's amazing the different orders of magnitude of risk that you're debating. And we have the same thing where Laura's parents and my parents were very worried about this whole time. I was trying to convince my parents to leave New York City, and they briefly went to Riverdale, and then they decided to come back. And we'll just never go outside the apartment. We'll have our friends bring us packages, and we'll leave them outside for 3 days, and it'll be fine, or something like that. But I still worry a lot. But no, it's been a very hectic 2 weeks for me and my family, because we have 2 young children. Alexander is 5 and Gideon is 2. And so we normally have a 2-bedroom apartment in Manhattan. And we very quickly dawned on us that being stuck there, even with a lot of food in the pantry, was going to rapidly drive everybody involved crazy. The nanny would have to either be with us or not be with us, and both options seemed terrible. And we wouldn't be able to get any work done, and it would be a complete disaster. So, and then the doubling time turned out to be 2.5 days instead of what I thought it was, which was 4 or 5. So I thought I had an extra week or 2 to do things. I thought I was safe. And then I wasn't, just like everybody else. So we went down to see houses here in Warwick, New York. And then we decided to stay an extra day and actually just rent one immediately. So we managed to close a day after we started looking at places, signed a lease, got out of our old lease, had all of our stuff was shipped here. We went back to New York actually 3 times because our awful mayor started talking about potential lockdowns and quarantines. And the last thing you do right before a lockdown is say you might have a lockdown, you idiot. So instead, we went in the car and got a friend to bring another car. And we just took all of the stuff that, Passover style, we just couldn't live without. And we just, ran away with 2 cars worth of stuff. Then we came back with a van the next day and got the stuff that we really didn't want to live without. And then we got movers for the furniture, which we did in 2 parts, because I didn't want to be in New York 3 days later to let the house be ready, among other reasons, because the infection rate was doubling every 3 days. And it seemed really like a bad idea. And on top of all of this, at the same time, we get news that my son's special education teacher is sick and she's getting a test and she's positive. So we get a test for our son, who's 5, who of course is asymptomatic because he's 5. And it's inconclusive because he wouldn't cooperate with the swab. We apparently couldn't get enough material. And so then we have to go back and get tests for us because we've now had long enough to do that. And luckily we figured out how to do that. And we got tests and we're both negative. So yeah, what's weird is that, like, this is actually relevant to our discussion. We were hoping it would be positive because by that time, Laura had minor symptoms and they had gone away. And I had not had any symptoms for a while. And it was like, well, if we're both positive now, then we're just immune, right? Isn't that just better? Like, yeah, we suffered a bit, but like what's done is done. And we got it through it before the hospital system got overwhelmed. And like, it wasn't our choice, but great. But alas, we now still have to debate, exactly how we're going to desanitize our packages and our takeout and so on, and trying to get delivery slots for the grocers. But it's still, we're settling in now to rural house life, and it's very different in many ways where you can't go anywhere, but it has advantages. And I think life is mostly returning to normal at this point, and that allows me to then, of course, spend a lot of my time obsessing over the situation of COVID-19, which is not what I was hoping for. I was hoping to get back to work, but we'll make do. So here we are. Yeah. So that's my situation. My dad's an immunologist, so I've been trying to consult with him to get more information. And apparently he was at least helpful in contacting Andrew Cuomo and getting him to do convalescent serum and antibody testing. So
Nice.
I'm happy to have at least done something.
Yeah. So yeah, we've been, just my update, we've been quarantined for a couple of weeks now, and I was successful in getting my mum to isolate and stockpile a couple of weeks early, which was pretty good. And yeah, now we had one person renting in, and they had sort of been renting for a while and been looking for a place, and they moved out, and we managed to help them get rent on a place for a month. And they moved out the day before the lockdown, and they were someone who was kept going into work and using public transport, so we're lucky to finally have the place to ourselves with just people who are down for isolating and so on. But yeah, otherwise, I know we've been working on it pretty nonstop at Less Wrong. We've been trying to summarize a bunch of the advice online and build some databases and doing a bunch of stuff. It's sort of been the full-time focus of the team now, just late nights and so on.
Yeah, it's weird getting half of my world news from rationalists over the last month. Between Less Wrong and Rationalist Twitter, it seems like a lot of the best information is coming from our circle.
I feel like I learned a lot about Robin, because I think Robin tweeted, you were writing about this mid-February.
Mid-February.
And then a week later, you were like, this has become normal now. This is time for me to leave the conversation because I have done all that I can do. And I was like, oh, wow, you try and be that ahead of the curve? Okay, that makes sense why you're not getting...
It didn't really work, I'm afraid. I want to make clear to everyone, we don't think we are suffering, especially compared to other people, and especially what's going to be happening over the next few months. So we just thought it would be good to relate everyone our personal stories to.
Look, we had a freak out set of 2 weeks that were very, very stressful. And we were briefly worried that maybe Laura's parents were positive or any number of things could happen. But yeah, it's nothing compared to people who are actually sick or actually on the front lines of this thing. We have enough spare cash to just go rent a place and move there and work from home and hide out. So, yes, we're going to be fine. And other people might not be. I mean, it would be, obviously, if our parents got sick, that would be very bad and very sad for us. That's the only thing that we're personally worried about. That in our stock portfolios, I guess, to the extent that we still have them. But.
Yeah. So moving on to the topic of discussion, which is the policy proposal from Robin. Robin, do you want to just take 5 or 10 minutes and just outline?
I will try to briefly summarize, and Z, feel free to butt in. So I don't know if you've told them, but we've decided to do a relatively flexible debate format where we'll just interrupt each other and go back and forth. And if the moderators decide somewhere along the way that one of us has been talking a lot more than the other, they might intervene, but probably that won't happen. So we're just going to talk.
Cool, great, go for it.
All right, so, and you guys have some links probably up with this on some of my blog posts, presumably. All right, so the basic idea here is to have a better plan B. Lots of people in the last month have been really hopeful that even though we really screwed up, in the first month or two of this, especially in the United States compared to many other places in the world, that we're the dynamic powerhouse and we're going to fix that. And we're going to therefore create unprecedented levels of testing and tracing and isolation, and we're just going to do a heroic job. And hey, it's our moonshot, it's our World War II, and this generation is going to do it. And you know what? That's a hope. It's real, and it should be pursued. But we should also be planning for what happens if that doesn't work, because up until a few weeks ago, at least, most experts in this area, most public health people were saying, look, it's over. It got out. At this point, it was where we usually give up. But so what if we can't contain this thing? What if it basically spreads to most everyone? And so most everyone gets sick. And therefore, even if sort of the estimates of 0.5% of the population who are infected die and half the world is infected, you're still talking, 20 million people in the world dying. So what can we do about that? So the usual story is flatten the curve. Try to lower the infection rate so that even though just as many people eventually get infected, they're spread out more over time so that they each have more medical resources available to them. That's the usual story. And it's a fine story, and we should be willing to pay substantial, though not infinite, costs to spread out the curve. And that's why we are doing a lot of lockdown sorts of things. But that policy has some perhaps neglected costs. So obviously there's huge economic costs and social costs just from messing up the whole system, and then a lot of people will be depressed and commit suicide and not get access to medicine, et cetera. But in addition, there's this key effect of dose size in infections. So when you are home locked down, you're much more likely to get infected in the home or get infected from some close contact you have. And those sorts of infections would tend to come up with a lot of copies of the virus in the first, if you kiss somebody, for example, in the first bunch. And at that point, it's a race in your body between the immune system, which is trying to grow up fast, and then the viruses are trying to grow fast. And the bigger that initial load, the harder it is for your system to beat it. And in the 3 other data points that I've been able to find clearly for death and humans, this death rate as a function of this dose varies from a factor of 3 to 30. So we're talking a really large factor here. And that's, for example, people are really obsessed with ventilators, like, do we have enough ventilators, et cetera. But apparently like 85% of people who get a ventilator die anyway. So ventilators can at most save 15% of them. So, a factor of 3 to 30 is just bigger than that. So that makes you worry a bit about the lockdowns. Although if you were going to be able to suppress it and then only a small fraction of people ever got it, that factor of 3 to 30 could still be worth it. But if we're actually going to go everywhere, it's not clear it's worth paying that factor of 3 or 30. But that raises another exciting prospect, which is we could go the other direction. Instead of accepting an average sort of infection rate that you'd get if everybody was just mixing, which is lower a dose rate which is lower than if you lock everybody down and make sure they have high contact doses. What if we go out of our way to do low doses and deliberately infect people with low doses? And this has historical precedent. This is basically the treatment used for smallpox up until the vaccine in the late 1700s. And reportedly from back then, it was a difference between a 20 or 30% mortality rate if you got infected naturally and a 1 or 2% rate if you got infected through the low dose. So we could start a policy of infecting people on purpose and then immediately isolating. Now, if you just go infect people on purpose, but you don't isolate them, you just speed up the whole thing and you make the flatten the curve thing worse. You're sharpening the curve. But since you're deliberately infecting somebody, you can go out of your way to make sure they're isolated right at that point. And so the idea here would then be to deliberately infect people. Now, of course, you could imagine a mandatory program and telling who to get infected, and people could be really upset. I would more imagine a voluntary program where the first thing to do is just make sure there is a place you're allowed to do it, and a place you could go if you wanted to do it, where maybe you'd have to pay to go, but it's like a hotel or something where there's some medical services there if you turn out to need it, but otherwise you're in your hotel room and you're infected. And in order to make that happen, we just need legal permission. We need to, which is some work because it's not clear that you'd have legal permission here. But if you could just have some group of people who have legal permission to do this, then you can set that up. And then the first 4 groups that did this, they would learn just how, they would try to learn exactly what the right way was to give you a low dose, and whether it should be a spit, a prick on your skin or through your mouth or whatever, what should it be as a way to get to you. And we would figure out exactly how far we could go in terms of lowering mortality rates. And then, of course, once it was successfully demonstrated, then you might consider a larger policy, which mainly I would think would be of the form subsidizing, i.e. paying people to volunteer to do this, so you get more of them, and preferentially paying some groups over others. Obviously, young people and healthy people are going to face a lower death risk if they do this, but they will contribute roughly the same amount to lowering the overall degree of infection in society and getting to the point of what they call herd immunity. So it would make more sense to infect the young and healthy, also make more sense to infect critical workers who you would make sure to need at key times and spread them, of course, when you did. And so that's basically the idea. And surprisingly, given how we have this huge historical precedent of smallpox, there's been very little discussion of this. I should also mention, I initially, 6 weeks ago, started writing about this in the context of flattening the curve, just from the benefit of, if you deliberately infect and isolate people, then you infect some people outside of the peak, and that allows them to get more medicine. And that's roughly 20% reduction in death rates, as I calculated, which I was excited about. And then last week, I realized there's this 3 to 30 factor in death rates, which is a much bigger motivation. And so that's my basic case. And of course, we can go farther in the discussion, and Z knows this, but the rest of you may not have. So,
right. So just to outline, so I do think that this effect is almost certainly real. We have low confidence in its size, obviously, the effect of low viral versus high viral loads initially, but it's almost certainly real. I do think that the initial proposal of Robbins to deliberately infect people to get it outside of the top of the curve, that proposal was expired just because we were already too late. Like by the time we ramped up deliberate infections, we wouldn't be able to flatten the curve that way anymore.
Maybe in New York City. There's a whole rest of the world that is not anywhere near the peak yet.
I think they're a few weeks behind at most, in most places. But I mean, certainly in New York, the peak is here right now. But my understanding is that right now, we're a few weeks away from peak. Hospital systems are going to be overwhelmed in most places unless we have extraordinary success with the social distancing.
But if it was a factor of 10, I mean, that you might still be tempted to use it even at the peak. If it was really a factor of 10 reduction.
If you were confident it was a factor of 10 versus what you would get otherwise, right? So one thing that I noticed when I was thinking about this carefully was that it's very important to understand what kinds of infections you would get in the wild, like how many people got low doses versus high doses versus giving everybody a low dose, right? Because you don't give everybody a high dose no matter what policy you're in, unless you're doing it something very malicious or on purpose. So one rule of thumb I asked myself was, what's the household size in the United States, as an example, right? Just to think about the American situation. The average American household is 2.6 people. If you exclude children that can easily be held home, who also just don't have much risk because children under the age of 18 basically never die or get seriously ill from this, to a first approximation, we're left with a household size that averages about 2.02, I believe is what I got. So at that point, if we're worried about high viral loads being modeled as coming from familiar interactions inside whatever your lockdown quarantine area would be, if someone else in it got it and then you got it from them, you assume you have probably a high viral load. And then if you get interactions like at the grocery store or otherwise like trying to make your way in the world normally under a quarantine, you would then probably get a relatively low viral load, right? Like with the study with the measles, the kid who got it outside the home was relatively safe, right? Like,
sure, but there are these, I've only been able to find these 3 data points so far. Maybe there are more, and I wish somebody would go look for them.
Right.
These 3 data points are about in the wild infections, and there are differences there. So the smallpox example is in the wild infections across a wide range of degrees of contact was producing 20 to 30% mortality. And then the deliberate variolation, they call it, was 1 to 2%.
Yeah. So
can I just ensure, Zvi, do you want to take a minute or two to outline all the main points of your disagreement?
Please.
As well as this one.
All right. So yeah, we'll get into this in a minute. But basically, my opinion is that we are currently not in a position, I think Robin would largely agree, to just do this on a massive scale. We have an idea, what if we did this, but we have neither the permission nor the logistical capabilities nor the understanding of how to safely give people a reliable low dose, nor do we have the extra tests to verify if they actually got infected, because if we do it right, most of them will be asymptomatic. And then we would have to hold them until we reliably thought they were immune. And then to have this work, they would have to be confident they were immune, which probably means getting antibody tests for them, which we also don't have. And, all of us on top of having, actively malicious FDA and CDC and WHO people trying to stop even ordinary mitigation and reasonable effects, let alone something like this. So, I don't think that this is particularly actionable right now. Plus the problem of, I think that, with a lot of low doses already, we're just not going to get, 3 to 30 is a misleading win. We're talking more like, 1.5 to 10. And then you have to consider the fact that not having hospitals available to save you, which if we did this at scale would just be true if we did it like over the next month or two in most places, would mean a factor that wasn't that much lower than that working against you. So I just don't think this is a practical thing to do right now, because we just can't spare the resources in various ways to do it properly, and we don't know how to do it. But I do think that we should absolutely run this and many other experiments that involve infecting people on purpose, or accepting that a lot of people who we experiment on will be infected, in order to learn much more about the virus in various ways. And I think we'll probably have broad agreement about those policies when we discuss them.
I think the UK maybe had an experiment for some period where you could you'd get paid money, you could take the virus, and they would do certain tests on you to try and test some of these variables.
Yeah, I saw a little bit of that. I haven't seen any results. Do you know if there was any results from that?
I have also not seen any results from that yet.
I think people were paid to take a different but similar coronavirus. So people weren't actually paid to take this coronavirus.
Yeah. And I believe that was, not the most helpful thing for us to do right now. I mean, it might be better than nothing, but it didn't teach us the information we want to know. Like, we could learn so much from so few infections, most of which would almost certainly end up being low dose in healthy people. And we're just not doing it. And
the latest Nature issue has an article about what they called human challenge, where what are the ethics of actually allowing people to be directly infected with the virus rather than infecting a whole population to get faster vaccine data. And they were like, not so sure it was ethical.
Right, which obviously makes both of us, our heads explode. But the word, biological ethics, right, like medical ethics, is almost an oxymoron when used in the wild. Just the things that they think about just don't make sense from the perspective of what happens to people in many cases. At least that's my perspective, and I think it's probably
that subject could take us the entire time.
I don't want to go off on I didn't mean to get off on a rant here, as they say.
And my model is you also under the impression we should there are a bunch of other low-hanging fruits that should be our primary next steps as opposed to exposing the youth.
Yeah, I think basically we are failing really hard on a lot of very simple things right now that we could push on that would greatly improve our chances of successfully squashing this, at least for a while. And that only after we've done those things and ramped up, so sort of a few months from now, we should absolutely look at our data from deliberate infection tests and look at where we are and how likely we are to be able to contain this in the long run and the economic costs of that, and ask ourselves, okay, should we be deliberately infecting now? And it's not obvious to me we should start with the young also. Like, a lot of my intuitions say we should actually start with the old, because if we're accepting that everyone's going to get infected, the primary win comes from the infection being mild, and therefore you want to save someone's life, you do it in an old person. Right? You have a person who's 23 gets a mild infection, doesn't save that much life because they were probably fine anyway. Person who's 87.
Well, so I did an initial analysis in a spreadsheet simulation, and in that thing, it turned out infecting the young was better. But of course, a more complicated model, including more things, might have a different effect.
I agree.
So it sounds like your main objection is about that it can't be done now, and or that it would have less effects than I'm claiming. So that second thing seems like easier to start with.
We were getting into it, and then we decided to outline things.
Well, sure. But I mean, from my point of view, I just say, well, we have limited data, but all the data we've seen has tended to see pretty large effects of initial dose and what they call viral load. That is, there's very strong correlation between viral load and symptoms in a great many viruses.
Right.
And so there are these 3 data points I could find, and they are a factor of 3 to 30. And if you're sort of saying 1.5 to 10 is just trying to say, well, there must be a selection effect there, so that I'm going to discount it on the basis of if people saw a smaller effect, maybe they didn't publish it or something. Is that
well, no. So I want to be very let's be very concrete about the example. I remember 2 of them very distinctly. I don't remember the details of the third one was the actual coronavirus, right? So there's that one. But so
one was smallpox, one was measles, one was SARS.
Oh, SARS. I forget what the details of the SARS one were, but so the details of the measles one, I believe, was a 14-to-1 difference between people who got it outside, the first person to get infected in a home, and everybody else.
Yep.
And what I was saying was you have to discount that by a factor of 2 because half of people will get it outside the home anyway.
Not clear.
Well, I mean, just because of household size, right? Like Americans, if you discount children, just the average household has 2 people.
Well, but if we're all locked down, then
I mean, you think we increased household size substantially?
I mean, it's about, close contacts. I mean, a lot of people aren't going to be all by themselves. They're going to make visits once in a while to see a close friend or family. And those are the times when they also might get a close contact.
It's not obvious to me that visiting a friend is the same level of high dose as living with someone. I don't know. Obviously, that's not the way it was done before. Certainly there's some possibility of that, but it's also possible that like a lot of interactions will be less intense than they would have been otherwise if people were taking a lot of precautions. Like certainly a lot of places that people,
well, I mean, if we take a factor of 14 and divide it by 2 and get a factor of 7, I mean, that's still huge, right? I mean,
it's still huge, but the issue being that like if we have a factor of 5 from the hospital not being available, those two almost get.
Do we in fact have a factor of 5 for a hospital not being available? I mean, that's less clear to me. This seems to me the biggest factor I can think of. What other factors are as big?
I don't know we don't know the number for sure. I know it was a factor of at least several. So with the smallpox was a difference between like a deliberate minimal infection and like the infections in the wild, right? Not just between a low dose, but like a deliberately super low dose.
Yes.
And I strongly agree that if we can get to a super low dose through experiments that reduces our findings even below current low doses by a factor of this kind of level, then we should strongly consider doing it. The other question, of course, is, do we think that everyone's going to get, to a first extent, everyone's going to get infected or not, obviously. But
right. That was that. I started out my presentation with that as the plan B sort of thing.
Right. We both agree that this is a plan B. Like we shouldn't like just jump to it if we don't have.
But if, we should go as far along to the path as needed so that we would be ready to invoke plan B. If we're not even ready to invoke it, then we, with all deliberate need to make sure that we get it ready to invoke.
Right. So I think the place that we violently agree is that collecting this information.
I'm thinking if for example, we allowed 10,000 people to be deliberately infected and then allowed people to vary the dose and delivery size, that would probably be plenty enough to learn about how to get a low dose and the right method. You would think 10,000 people is a pretty small number here.
But we should, like, for the perspective of if we, didn't have people literally standing in our way with guns, right? We should absolutely do this. We kind of do, right? We have people who are telling us we can't, right? This is very much not considered an appropriate thing to do. And anybody who tried to do this in any kind of controlled setting, right, in any kind of public way.
Well, so I think in some sense, civil disobedience should be left on the table as an option. Not yet. But we should try to do this legally. We should try to do this with permission. Yeah. But if we're talking these large factors of gain, at some point you might want to allow or even encourage people to do things that aren't permitted.
Yeah, I mean, I think that if we can run the experiment such that we will actually get the data we want, so we can actually not just haphazardly infect people, but infect people carefully, collect the data, do the testing. Of course, we still have to get the resources necessary to gather the data, which would have to come from somewhere. But my understanding is at least some amount of testing is just not being allowed by the FDA. There's capacity to produce a lot more tests than we are, and we're just not being allowed to do so because they weren't sufficiently accurate or whatnot, and we could potentially use those.
Although there could be a difference in permission in some university or lab trying officially to do a test, and a bunch of us just infecting ourselves, but then collecting the data together.
I mean, that would be the hope. But basically, this is one of many experiments we are not doing, right?
But we're talking right now about whether to focus on doing this. So we're asking this relative to other things we could focus on, its relative potential and priority, and what we could be doing. So I want to make the argument that even if you're not ready to pull the trigger, and I'm not clear that you shouldn't pull the trigger, we'll talk about that in a moment, that there's a lot to do here with high leverage that somebody, a foundation or philanthropist or whatever, could go a long way and do a lot to help with this just by first investigating legal permission and finding a way that somebody somehow could do it legally, and then finding a way to set up a place, even offshore, where you could go do it for a small group so that we get the sort of data and a demonstration Because I think if you could even do it at the small scale and then publicize the results, that could go a long way toward enticing a lot of other people to consider it. But so the limiting factor is that first demonstration.
Right. And I didn't mean that we shouldn't do it, right? Because we have so many other experiments we should run first or anything. We should run all of them, right? No, they don't preclude each other in any way. Like one of the few studies we have was a reasonably terrible in many ways study of 30 people in France, and that caused medications that people need to be just sold out everywhere almost immediately because it looked promising.
Yeah.
So that's how desperate we are for data, right? Like whether or not it ends up working.
So there's this other point you made about it's too late. And so let's go through different scenarios and ask in which scenarios are too late. So one scenario would be the current doubling every 3 days just considers until the entire United States population is done. And well, I guess at that point, we're talking another 4 weeks, right? So
and then it depends on exactly where you think we are right now. Like my best guess is we're at several million. We're at 1% infected at this point in the US. So 1, 2, 3, 4, 5, 6. Yeah, we got 7 doublings left and then everyone's infected. So that's 7 times 2.5.
Right.
So,
okay.
Yeah, it's over 2 weeks.
So that's one case. So in the case that, basically most everyone gets affected within a month, it's very hard to do much of anything, of course, in terms of policy. And then you would have to face the question of, do you want to try deliberate infection near the peak under the hope that it has a lower rate on the basis of data that isn't as direct as you'd like, but is still relevant data, and then you'd have to be making a gamble. And so even for those people, if we could just get data in the next few weeks that helped pin down, even just doing better literature review to find other historical cases, I mean, that's a really cheap low bar.
Obviously we should do literature review, right? If there are people who are just sitting around at home doing ordinary academic stuff and we can hire them to do a literature review, some billionaire should hire them to do a literature review. That's a slam dunk. Like, I don't see how anyone could possibly disagree.
But another scenario is the lockdown works temporarily. It doesn't squash it and make it disappear in a month, but it holds the line, or holds the line in some places, grows in other places, declines in other places. And now you're looking at a many month, perhaps even year-long scenario of alternate intermittent lockdowns. And in that scenario, it seems like there's plenty of opportunity for deliberate infection to, as a policy, even 4 months from now, to show up and have a big effect.
Yes. So when I say it's too late, I meant it's too late to do it sort of to lessen the initial peak, right? The initial peak is going to happen, whatever it is, without any chance.
But if the initial peak is as fast as we fear.
Right. I mean,
if we successfully lock down enough to spread out the peak substantially.
Right. I mean, I think the scenario where it ends up being sensible to deliberately infect people is in fact that scenario where we are able to somewhat contain it, buy ourselves some time, ramp up our available resources, but it's not good enough to squash. Right. And it becomes clear that we can't. Right.
I'm happy to I'd say, well, among the things we could do in the next month while we're trying to squash, getting ready to have this available, should we partially squash successfully, seems a pretty high priority. The only other things would be is what would it take to actually make us successfully squash? But it's not, most of us can't personally work on testing, and the government is supposedly going to set up a big, agency to do tracing. And I'm very afraid that they will just be incompetent at that and make a bad job of it. But if we could help with that, that would help under that scenario. Because basically, to do this successful squashing, we'll have to not only lock people down long enough, we're going to have to set up a regime of very high levels of testing and very high levels of tracing, which probably includes a fairly high level of privacy invasion.
My understanding is one of these things where you have a variety of things you can do. You sort of start with this R0 of around 4, which varies a little bit by place. And then you can engage in a variety of different actions to reduce that, to help you stop the spread. You successfully go well below 1, you win and you squash. As long as you keep it below 1, you get to keep squashing. One of the things you can do is test a lot. One of the things you can do is do more aggressive tracing on people you've tested and invade people's privacy. You can also do things like get people to wear masks, get people to continue to socially distance to some extent, take other proper hygiene precautions, et cetera, et cetera. You can also do deliberate infections. Obviously, one of the things it does is it helps with that.
Right, but I'm asking specifically, well, what would you put up against this research program as something that you think is something people who are listening could get involved with and do something with in the next few weeks.
Right. So personally, what I have been involved with is actually trying somewhat to increase capacity / push the government towards taking better actions to increase testing capacity and actions towards treatment. And that has had some success because I happen to have some channels, but that's
So
not.
we're talking testing capacity or medical resource, other medical
No,
capacities, or?
I mean, we actually set up a lab to do tests and actually got people running tests that wouldn't otherwise been run. So we did in fact ramp up our testing capacity somewhat. And then the FDA said, you can't run that test. So that is, of course, how it works. We also managed to get Cuomo to pursue antibody testing and convalescent serum, but that's obviously a uniquely good success. So a number of people in our circles have been pursuing messaging, trying to get the word out about various low-hanging fruit that people could pick in the hopes that other people would pick them. We also obviously could try to get word to people with resources to try and pick some of that fruit themselves. There are a lot of people listening, I think, including Ben, who have primary or secondary contacts to people with a lot of resources.
So I'm hearing a lot of meta things, but I'm less hearing
specific. All right, concrete.
First, you just make some tests. You say, okay, you could be making some. Lots of people are out there trying to make more tests right now. There's a world full of people trying to make more tests, and obviously, as you say, regulation is more the barrier.
I mean, I strongly agree. So if it is feasible to run experiments on COVID-19, to find out more about how COVID-19 works, what leads to better or worse infections, what leads to what infection rate, on what actions, so people can know what to do. That includes things around, will almost certainly involve a deliberate infection incidentally, even if that wasn't like the intended purpose. I do think that is all very high priority. I think that like finding out information through experimentation seems to be by far the most efficient like local thing that anyone can do.
But again, I'm saying you're drifting into abstraction, and so I'm trying to pull you down to concrete. So you're talking about messaging and networking and experimenting, which is all at the abstract level. But this proposal of mine is relatively concrete. Yes, these meta things do help and add leverage, but it's about a thing you can concretely imagine. And I think one of the advantages is that instead of just trying to encourage the government to do better, which is this amorphous thing where you're trying to pull all these levers and there's all these intermediate variables you can't see and that matter a lot. This is a relatively simple, straightforward thing to implement. If you say deliberate infection means you have a place, they show up, you infect them, you keep them there until their symptoms are subsided or 2 weeks, plus later, and then you let them go. And so it seems to be harder to mess up as a method. And it's obvious that even if you do a bad choice initially about exactly how to initially infect or even where to have the location, you would quickly learn that people don't want to go to that place. They want to go somewhere else. They want you to have better curtains or beds or whatever else it is. You would learn in the process of doing that, and you would get data on which methods are better, most effective. So part of the advantage I'm suggesting here is, yes, you could mesh it about it. Yes, you could network about it. Yes, you could do all these abstract things that you can do for anything. But here is a concrete, simple proposal that's hard to mess up.
Yeah. So like in terms of concrete, simple things, I hear people like just trying to physically like get equipment to the right places and stuff, where we certainly have much more leverage than people would think. Because I've seen a number of.
We're talking ventilators then, or?
I've seen ventilators. I've seen masks. I've seen in my case tests, actually some physical tests, like we've gotten people tested that needed to be tested out of thin air. But yeah, I agree that there's a lot of people doing that. That's ramping up on a logarithmic scale almost the virus.
So on those categories, if you say how much effort is there and what percentage effect am I adding to efforts to get masks to people or efforts to get tests to people, I mean, you got to say like you personally or you whoever's listening is a pretty small fraction of that, because a lot of people
it's a small fraction. I still think I'm just like I don't want to discourage people if they're considering doing those things. I think your leverage is better than you think it is. Like if
okay, but I'm talking about a thing that almost nobody's doing anything about.
I'm going to get to that.
So your personal leverage is much higher on this, I would say.
Absolutely. So to get to that, so when I said experimentation, I was trying to be concrete. So you're proposing like you infect some people and then you see what happens to them, and then you as your primary thing. So if I was trying to just like use what resources I had and was like able to do things that might get people infected, I would be doing something that was trying to kill more birds with that stone. I would be saying like, let's study exactly what leads to more. Let's study practical types of interactions that happen in real life. Let's see what causes people to get infected and what doesn't, and what rates. And then once they're infected, let's not waste this opportunity to study what happens to them exactly afterwards, based on those means. And then if we thought we had a way to introduce very, very small infections to them, and maybe get a good prognosis, and we had the ability to run that experiment, then we should absolutely do that. Once we have, the mechanical idea how to do that, I don't know how hard it is to try and get smallpox levels of exactly the right amount. My understanding is that it was an art form that was developed over a very long time, exactly how much you needed to get the person to be infected at all and actually have an immune response. Because if you do too little, nothing happens. And then
sure, but with enough cases, that would be an obvious parameter that you'd experiment with.
Right.
People wouldn't forget to look at that, of course. They would.
Right, and the question is,
and within 10,000 cases, I'm pretty sure you'd get that parameter down.
If we get 10,000 cases. So the question then is, do we have a reasonable path, right, to actually cause this to happen?
So, moderator, I thought we were initially thinking of 45 minutes and then a break. Is this about when you were going to do the break?
I was going to maybe head for another 5 minutes, but
I think we should keep going given where we are in the conversation. But I'm very curious to hear how you think that we would do this.
Yeah, no, that seems solid. Let's go for at least another 5 minutes. Go ahead.
So, the fact about this proposal is that a lot of people hate it.
Yes.
So that's both an obstacle and an opportunity in that if you understand that you don't hate it, you understand that a lot of other people are put off from it. Therefore, your participation and effort could have much higher leverage. This is something that, I found 5 other people who have written on the idea in the last 4 weeks who have posted something on it. And, they're not doing that much with it. So there are things you personally could do, which would have especially high leverage, just because almost nobody is working on this. Now, obviously, one of the things to do is to focus on how to present it and how to get it legally and culturally, framed and engaged so that it has the best chance. But you also have a high leverage with respect to that, because so many people initially react to this so badly that almost nobody wants to talk about it. So I've even there's a research institute that I have an association with, and they were calling for proposals, and they were handing out lots of money to people who wrote proposals that want to do something, but they rejected mine without comment because, I presume they said, no, we don't want to be associated with that. That's the kind of thing that's going on all over the place, which means that if you are the sort of rationalist who says, no, but this makes sense, you are an unusual resource, and therefore your efforts could have unusually high leverage relative to masks or ventilators or tests, which lots of people get are a good idea. And for them, it's just more a matter of how to do it. So that's my basic pitch, is that because the current effort is so small and the potential is so huge, you have a better shot, if you are the sort of person who doesn't throw up when you hear this, of jumping in on this and trying to work with me or others and figure out a way to make it work. And you ask me many questions, how would we do this? I don't know, because there's almost none of us working on this. So
right. So the proposal is not
around and say, come help
right.
Figure out how to.
So the proposal is not to spend a large percentage of the nations or worlds or anything efforts on this problem. The proposal is to use our specific resources to try and just make it happen on the side while no one is looking, kind of.
In the hope that with a concrete enough demonstration and a big enough effect, you could then entice lots of other people to try it. I think getting a large fraction of the population to do it isn't crazy, but it wouldn't happen on the basis of merely the evidence or arguments we have now. It would have to be mediated by concrete demonstrations. So then the question is, how can we get those demonstrations going? And of course, that's what happened with smallpox. Smallpox variolation, it was initially very controversial. And many people thought it was a terrible idea. Just the same sort of emotions that create anti-vaxxers, the horror at being infected with something that might be real was even more then, because this was in fact the real thing they were infected with. And imagine people in 1700, the sort of ordinary people back then, and how they would react to these proposals. A lot of them really hated it. Nevertheless, it became adopted in a standard practice, and in part because elite intellectuals, including famous mathematician Bernoulli, went and did a lot of careful intellectual work to demonstrate that it was in fact, not only empirically worked out well, but in abstract modeling and analysis, it would be good overall for society. Yeah,
it was a very overdeterminedly correct thing to do, given once they got.
Which doesn't mean it actually happens in our world, unfortunately.
And it still was very hard, but eventually, a lot of people ended up doing it, although definitely not all. No, true. And so, right. So the question is, is there a practical path for us to pursue. And so your answer is that just like you haven't gotten that far. You wrote a grant, and clearly they were the wrong people to ask.
But I mean, just more people thinking about this, even doing simple things like literature review, doing some legal research to find legal scenario options, even just knowing what it would take to set up a facility, like a hotel with medical facilities. Are there things like that? Could you use an existing elderly care facility for this purpose? There's just a bunch of things to just go do to try to figure out to see how we can make this work.
And I would say,
if I'll jump in there, this seems like a good time to take a break. Hopefully when we'll come back, we'll chat a bit more concretely about how we expect it would actually go down, how likely we expect it to fix into the various win conditions. I currently, I'm not actually very able to pause the live stream, so I'm just going to ask you both to turn off your video and audio in the bottom left of the thing for the next 10 minutes. So it's currently 12:50 according to my clock. So we'll come back
resume at 1.
Yeah,
right?
That sounds right.
Okay.
All right, and see you guys
when?
1. So in 10 minutes.
Okay.
4 for you.
On the hour.
Yes, got it.
Yeah.
Cool. See you guys then. Thanks.
All right. Hello, hello.
Hello, hello.
Hello?
Hey there, Robin. Is your video coming on?
Oh,
Yeah, just hit the button. We're good.
Welcome back.
hi.
Yeah.
All right. So I thought I would, I'll just try and summarize what I understood both of you to be saying, and then we'll see where to go from there. So my understanding, so Robin, I think you opened by saying two of the main things that seemed relevant to you was that infections in young people tend to be much less severe, and on the road to herd immunity and so on. And in general, this means that infecting them is going to have much less bad outcomes than infecting old people. And the other important part was that you realize this important point about the viral load hypothesis, that it seems quite plausible that ways that many people are getting infected is being infected to a very large viral load, perhaps in the house with someone they live with. And if you can infect people with a very small viral load, this tends to have much less severe outcomes. And so we could systematically make sure that everyone who gets it has a much less severe version of it. So then you started with that. And then I think Zvi came back with sort of three main points, which were that we're currently nearing up to we're heading towards the peak sort of continuously, or to a major peak. And the last thing you want during the peak is to have more people infected. Just when the hospitals are overrun, that's just going to be the worst time to have more people infected. Is the other point, I think the second point was that we already have a fairly limited medical capacity, and it is unclear that we actually have any slack at all to like execute this sort of thing. And then the third point, which was discussed, which is slightly meta, which was that people are currently coordinating around important low-hanging interventions like more testing and using masks and so on. And that is currently not like successfully been affected, and that's where he feels like marginal effort should be put. And to which I think then Robin replied, talking about this is a sort of weird idea that if you're the sort of person who can deal with weird ideas, it is quite plausible that actually your leverage here is just way higher compared to those other things that a lot of people in general seem to be able to get behind. That's my current summary of the thing. I'm curious, were there any key points that I missed, or did I mischaracterize some of the things you guys said?
So just at the beginning, my initial point was just deliberate infection plus isolation allowed you to move some of the cases away from the peak. It was less about young versus old. Given that you're going to do it, it turned out in my analysis to be better to do the young. But the main point was that you could flatten the curve via deliberate infection, even if there were no dose effect. But that I recently realized the dose effect. Anyway, that was the one correction I wanted to make.
That checks it. Zvi, did that seem like?
Yeah, no, and I respond to that with basically that like we maybe could have done that if we had done it early and done it properly, as in like the quarantine didn't break at all and so on. But that I find it hard to model that like doing it before we hammer the current peak doesn't seem like it would be useful in that way. But
so your lesson was that sorry, I just want to finish something first. So your lesson is, sorry, this is a dumb thing, but your lesson is we should listen to Robin earlier when he writes blog posts.
I mean, definitely we should listen to Robin when he says something unique and new and think about it. Like, because again, we're the people who are capable of thinking about such things. Like, I like to think that when I say something, or many rationalists say something like unique and weird, it's worth spending your time to think about it, even if most of the time you think, oh, that's wrong, and go about your day.
So I'd like to make an argument here.
Sorry, I just want to have a few more things. So we will move to a Q&A shortly, and maybe somewhere in the next 15 to 30 minutes. And if you want to have a question, the correct place to put that question is either in a comment section on Less Wrong on the event for this post, or to PM user Jacob Lagrus, or his username is Jacob. And if you pick your question, he'll send you a Zoom link and you can join in on this call and chat with us.
Okay.
Yeah, it's modern technology. It's all right.
Great.
So my main. Sorry, what was that?
I thought we'd just be reading off the questions. This is much cooler. Yeah.
Yeah, no, we tried it. I think it's going to work all right. It's like radio. So my main 3 senses of places we could go further, which I want to say, and then you guys can figure out what seems juicy to you. I think there probably is disagreement between you about like how likely the win condition is going to involve substantial amounts of deliberate infection, whether it looks like the sort of herd immunity thing or whether alternative win conditions are necessary. And I think another thing, so Robin talks about the ick reaction, and I think I have one of my main guesses for why people have an ick reaction is due to the potential for major downside from from deliberate infection, is the potential for either like we do it in a bad way that it causes a containment failure, or just we infect a lot of people when there in fact was an alternative method that did not involve herd immunity and did not involve causing everyone to actually go through the disease. And so there would just be a massive number of deaths that would not necessarily need to happen. So that's my sense, and if that was one thing that Zvi wanted to follow up, and that was some of Zvi's sense.
Yeah, I mean, I would say that, and I think Robin probably echoes this based on what I've seen him write and say mostly, that that's not the main place. Those are not the main places the factor is coming from. Like those are the places that, like you said, if you're trying to come up with reasonable objections, reasonable reasons people might be kicked out, as opposed to the actual reasons people get kicked out.
But
Robbie,
there is a place for responding to excuses, even when they aren't the real reasons.
Right.
They often force people to give a next excuse and a next excuse until you finally maybe eventually get to the real reasons.
And I do expect that some people. I agree that many people's reactions are not very thoughtful, but I think there's like still pretty solid place for reason.
But I actually agree with Ben that in many even rationalists' mind, they have hope, and this in some sense feels like giving up on the hope. That is, once you just try to infect many people, then you're giving up on the vaccine that will save us all, or the squash that will kill it all. And they put a substantial hope on those things, and this feels like giving up.
Yes, and you're not allowed to give up. Like that's really terrible to give up on human lives.
Or to make a plan B in case you fail is even really terrible.
Yeah. Making a plan B is already like escapism and pretty terrible. But certainly like actually doing it before we're sure we didn't have a way.
But not only making a plan B, but exploring and putting resources into figuring out which plan B would be better.
Well, because like you're stealing, like I can just imagine
resources in plan A.
Right. Like people are dying because you didn't give them tests. Like, how dare you, sir? You could have built a hospital instead of building this research clinic.
Sorry, so I do want to check. So that is like an important question, whether it is giving up hope or whether it is in fact like, whether it's a serious argument that this will not be necessary and it will on net just actually be damaging to go down that route. And I do want to hear more as Zvi's. Also, I got some feedback that we should talk a bit slower during this debate.
I don't think that's possible. I'm sorry. They can just slow it down on their video and watch it later.
Ooh, I got it.
That is interesting. It will be difficult for the people who want to stick in for the Q&A themselves. But yeah, that seems...
So I had a couple of things that I thought we might be able to fit in. One is I just wanted to make a list of all the like concrete things we could do because I realized it didn't include all of them. Another is we might be able to go over the bad arguments we agree are bad, and that might be a contribution we could make.
Yeah.
And then the other thing I was thinking was the argument that say there was a factor of 3. So I say that the data range is a factor of 3 to 30. So say it's only a factor of 3 in mortality reduction, and say we're at the peak. Well, this mortality reduction goes with all the other symptom reductions. That is, all the way along the chain to death, you're also having weaker symptoms and less problems. So I would think if you take 3 people and you deliberately infect them, that's the equivalent of 1 ordinary person in terms of medical demand. So if you think most of those people are going to be infected near the peak anyway, it's not clear to me that even near the peak, you shouldn't want to do deliberate infection in order to get that factor of 3 to cut down the medical demand by the factor of 3.
So yeah, let me think about. So if you have those, if those resources don't have a better use somewhere else, including in isolating people, like my model says, even if we're at the peak, like it's very possible to actually protect yourself if you're willing to take proper precautions.
Well, so my assumption is that you infect plus isolate. So my general policy is that in order not to accelerate and make the peak sharper, whoever you deliberately infect, you immediately isolate. So, and then it's in my calculations, my simulations, I accept that displaces 1 other person who might be otherwise isolated. So that I'm not just assuming more isolation, which of course we can.
Right. The alternative is to isolate somebody who is not infected at all and have them just stay safe.
But I was focused on the medical resources argument that if the argument is that at the peak, you don't want to be doing this because you're taking away, you're adding to the load of medical resources, I'd say, well, no, you're not. That is, deliberate infection doesn't actually sharpen the peak. It actually can flatten the peak. And again, you'd be swapping 3 people who will soon get infected anyway with 1 person who's now infected.
It depends on how long the peak lasts, right? If the peak is only a month, then by the time you let this person out, they could have just never been infected and the peak is already over. And you've taken some amount of resources to help them. Whereas if the peak is going to last for longer, you can rotate people in and out and you can actually make progress, right?
Well, there are different kinds of quarantine or isolation resources depending on whether you're trying to prevent infections in or out from it. People you deliberately isolate and infect, you're not so much trying to prevent infections from coming in. You're trying to prevent infections from going
right
out.
After the first day or 2 where it could increase the viral load, you're like, okay, it's done. you're infected.
Right. So that's a different kind of resource.
No, it's a cheaper isolation is the argument, because normally
But
you
you
have
can
to go,
basically have a hotel of people where they all come in on the same day and they all get infected the same day. They can wander around and meet with each other and do everything they want. You know, they can all be in contact with each other. You can even have a university campus that way. You
I mean,
have armed guards around the edge, but you know, everybody comes in on the same day.
it's a little trickier. Like you still have to verify they're infected, right? Because like otherwise they'll get high viral loads during the secondary infection.
Right. So the first day or two is they're isolated and individually infected. But then
So how fast do the tests work? My understanding is the tests take several days before you will get a positive swab from them, because like you haven't had the virus multiply enough yet. Is that right?
Well, I mean, in this case, we could just say it's a week of isolation plus a month, perhaps,
Right.
of shared
first-
isolation, right?
The week is full cost, then you have to burn some tests, and then you have a cheaper isolation after that.
Right.
And it's not so. It's not clear to me like how like my isolation, for example, right? How expensive you should consider it, right? Like if you actually know how to isolate, like how hard is it? It's just like
Well, but under your assumption that isolation isn't that hard, then by assumption, this peak is not going to be all in 1 month. It'll be spread out perhaps over 2 or 3 months, right?
Yeah,
So
isolation-
your assumption about the feasibility of isolation is directly connected to your prediction about how sharp.
right. It depends on like it's possible for some. Like certainly one way one could invest if one had a lot of resources would be to like actually improve isolation procedures to allow more people to be isolated and potentially flatten the curve. Like
if
from
that
now on.
was, and you know, for example, you know, effective delivery of groceries or mail or something, if somehow it was easier to make that more clean.
I
that could be
certainly
a win
think
there.
I certainly think that's another place that like we could think about, because like nobody's really looking at it very hard right now as far as I can tell, and they're not scaling up very fast. And I mean, obviously it's not the same thing where like we could convince everybody to suddenly do this giant thing that would have a huge impact, but certainly it's a possibility.
I mean, again, I'm certainly not going to say the thing I'm proposing is the only thing worth doing.
Oh, yeah.
That certainly sounds worth doing. And in fact, so in my experience, I see all these firms telling me that they want to deliver me food and things and telling me they're being clean, and just having some third-party independent verification of, or, you know, certification of cleanly delivery could be a huge contribution. Maybe it's not so much some clever way to do it, but just certifying that it is clean.
Yeah,
'Cause
that would certainly be good. Also, just ramping up scale. Just to speak from personal experience, like we can't get delivery here because all the delivery slots have already been taken, and as fast as they're appearing, they're just gone because, of course, price mechanisms. Who knows what those are? So it's just a matter of like furiously trying to click. So we're going to get you pick up instead, in the hopes that like we'll actually be able to do that, and then that's still like, you know, an order of magnitude better than going into the store. Maybe 2, but like not great.
Right. But we can expect ordinary interest in market mechanisms too over the next few months to be honing and improving isolation mechanisms, right? And so if they succeed enough, then that will flatten the peak. And that means we're not talking, you know, 3 weeks until the peak here. Maybe we're talking 3 months.
Right. I have a model where super spreading and like different people taking different behaviors matters a lot. And so there sort of will be a peak amongst people who can't isolate, where the isolated people will largely ride it out. And then the people who aren't isolating will largely have recovered or have gotten sick. And then the situation changes. But
so the more this is spread out, the more an opportunity is there, at least for the last third of the distribution, for it to get deliberate infection, right?
And then they can certainly consider it. Yeah. Look, so I think we strongly agree that if there was a practical way for us to be allowed to and actually run this experiment, it would be much better. It would be a very good use of resources. I think we both agree there's also a lot of other similar things you could do if you had the ability to engage in medical experiments on humans with live COVID that would also be well worth doing. And like we can talk about exact procedures.
Well, so I mean, this is simple enough that the question might be, do we necessarily need an officially sanctioned large, you know, and sponsored and run by a big major organization sorts of experiments, or what sorts of smaller scale, more amateurish experiments could be done here that might be sufficient?
Yeah, I mean, I'm not a legal scholar. I imagine that if anyone gets into trouble, if anyone gets sick, you're in a hell of a lot of trouble, and maybe even, and you might even go to jail if no one does, because this is
I think you're especially probably in a lot of trouble if you're trying to sell this. If you're a for-profit business, then you would be sued, into death.
Oh no, yeah, a for-profit business, no way. Like,
but if you were simply amateur people helping each other, then it's less clear that there would be much somebody, that could be done. Like if you showed somebody a kit for how to do deliberate infection and you posted the kit on the web, and then some people decided to use the kit, could you really be sued for them deliberately infecting themselves? And taking that risk might be worth it if you're just one person who, what can they get if they sue you?
I mean, I would not be worried about being, I'd be somewhat worried about being sued. I'd also be worried about being criminally arrested.
Okay, but like, if we're talking, like even in the United States, I guess I recently, did a bet with someone about a quarter million people in the U.S. dying. If you could actually make a substantial cut in that, is that worth, civil disobedience at some point?
Look, I'm not going to tell
the hell with the
people.
rules.
I'm not going to tell people not to do it if they're willing. I agree. I'm trying to find a practical way. Obviously, also, if you want people to report on and believe and use your findings, you really want to be able to do it as above board as possible, obviously.
Of course, but there's a trade-off here. But again, if it's a choice between doing something soon and fast and getting it done versus waiting 6 months for regulatory approval.
So Zvi, I would like to just ask if you want to just take a minute to reflect and see if there's any other you hit all the key disagreements you wanted to bring up with Robin's proposal, or is there any others you wanted to?
I would say I certainly had additional concerns about the proposal.
As do I.
Yes, but I don't think it would be necessarily a good use of time to bring them up right now. I think going to Q&A. I think
my guess is we'll go to Q&A in a minute. I will wait for Jacob to tell me that he has got two people ready, or got someone ready in the room.
Right.
So we'll probably just go for another couple of minutes.
Well, I'd like to just list the things that can be done here.
Yeah, let's do that.
Just in the hope of enticing someone to doing them. So I didn't mention before computer modeling. So a lot of people we know love to do computer things. So my little computer sim is, badly done because I'm not, in the habit of doing that a lot. But even just the question, would it be better to deliberately infect the old or the young? If there is a large reduction due to dose is not obvious. And so it'd be worth doing some modeling to figure that out. And so people we know could do computer modeling of that. Even coming up with a simple sort of dose experiment plan. If you were going to deliberately infect some people, just what would be your plan in terms of, in who gets what, when, and what you check. Somebody with competence in doing that should just, figure out a plan. Those are two other things that I didn't mention before, but of course I mentioned before some sort of facilities planning, either for a legal thing you're doing above board to figure out like what place you buy and who do you hire and what do you staff it with and what's the plan there, or some perhaps, amateur coordination thing and what would be the plan there. Legal research about figuring out what versions are legal, and then some sort of literature review to better pin down what are reference points for other data on dosage effects in viruses like this one.
Yeah, I would add to that. So we need people who actually know biology and immunology and how to work with viruses, who can potentially explore how to do it, like physically, like if we actually got
how to create a low dose, what would be the best mechanical way to isolate it, save it, and then deliver it.
If anybody knows how to potentially find leverage with people who are in regulatory agencies, potentially get approval, that would be potentially very helpful. One thing I was thinking was we could try and actually just gather data via, it's not as good as doing experiments, but certainly we could try to use surveys and asking questions to try and find out more about the people who actually just naturally got infected and how they got infected and how that compares to how their cases went, and just try to see if we can establish something that way.
Well, in fact, there was a study I saw in China recently, which looked at how people got infected in terms of the chance they got infected, but it just didn't look at death rates. So maybe you could just get their data and recrunch it and figure out how death rates relate to the mode of infection.
And just look for more natural experiments, look for places where we can ask these questions.
But quite often, you don't need a new experiment. You just need to go find old experiments people didn't analyze right and just get their data and recrunch it.
Yeah, that sounds promising too. And obviously, like if we wanted to do this with building facilities and such, like having somebody who's willing to back it, on a philanthropic basis would be wonderful. I think going to a grant is hopeless in the situation for obvious reasons. I don't think that
just because I wasn't applying for a grant, I was just applying for them to put my proposal and text on their website.
I think even that's pretty hopeless. I think what you're hoping for is specific people who have specific people who have a lot of money, billionaires and like multimillionaires who
opportunistically find people who can help. Obviously, yes.
Yeah.
All right. I think we have a first question. So I'm going to invite them in the room and ask them to tell us who they are and what their question is. I think I maybe know who this person is.
Oh, that guy.
Good afternoon, Oliver Habrica. What is your name and what country are you calling from?
Hello.
Yeah. What's your question?
Great. So my question is, my current emotional status is something like, something about this seems really good, but what I really want is two of you giving a bit of background on like, what could possibly go horribly wrong with this? Some of my intuitions are that like, this seems good, but a part of me just assigns some probability to this going horribly wrong. Like a case might here be that our viral load, like turns out we mismeasure it drastically and we increase it drastically. We completely block a containment measure. Like, what are the guesses that you have for just like, what is the worst case that could happen? What is the probability of that? And what are some easy ways we could mitigate that?
I'd say, obviously in the amateur scenario, if you are trying to create samples and store them and deliver them, you could accidentally infect people with other things by doing a bad job of that whole process. So there's a reason why professionals produce medicines in the way they do and the way they store them and the way they deliver them. Amateurs trying to produce substitute, that would be a scenario, bad scenario, right? So I'd much rather have a professional do this than amateurs to avoid those sorts of scenarios, right? So you can imagine like they just infect it with some other random thing in the process of packaging it together and poking you with a needle or whatever they're going to do. You can just screw that up. That would be one. And obviously another thing is like, say some church likes this idea, their pastor goes wild for it, they do a big thing, and then they screw something else up and they all commit suicide. And then like that's in the news, like, and this gets associated with some weird disliked group, and then that's the death of it, right?
I mean, certainly we have to worry about facing giant social backlash, whoever tries it, facing potential legal backlash, stuff like that, shutdown attempts. But like when we ask them, like, I think bigger, like what could possibly go horribly wrong? So one thing that could go horribly wrong potentially is that the selection pressures of the procedure somehow cause the virus to mutate in a very nasty way that causes it to be harder to detect or last longer or something like that. Because like you're quarantining everybody you're infecting tons of people and then quarantining them for just long enough that you expect it to die. And then the version of it that can live for 50 days and still spew without being symptomatic suddenly gets out. And now everybody has to quarantine for twice as long and it's a disaster.
Just to be clear, we're already risking those sorts of things with lockdown. I mean, people have suggested that.
You're increasing, just potentially you're increasing the probability of that happening. I'm brainstorming things that could go horribly wrong, right? Second thing that could go horribly wrong is, as was discussed on Twitter this morning, if people aren't immune for that long, I think we both agree that like it's going to be more than a few months almost all the time. But if we infect everybody and a year from now, a variation comes out because this is still endemic, no matter what we do. And then it comes back and previous SARS coronavirus style infections, in some cases, prior immunity to other strains has made infections worse. So by infecting a larger percentage of people, even though they recovered, you could set yourself up for bigger problems down the line.
But that's a problem with any way in which most people eventually get infected. That's not particular to deliberate infection.
Yes,
mechanism.
Yes, but
it's just any way in which if we let most people get infected, then we risk that.
I mean, I'm assuming that with deliberate infection, we end up infecting. I was assuming we ended up infecting more people than we would have otherwise.
I'm not assuming that.
Well, right. I mean, I was thinking like once we have the ability to infect people relatively safely, like versus taking that risk, we kind of would keep going. But I don't know.
I mean, there would be a moment in time where you could pull the trigger and then deliberately infect everybody, say within a month. If the vaccine showed up in the first week, then you would say, oh my goodness,
Right. The obvious other thing that could happen is like the vaccine shows up a month later or a treatment shows up later. And then everybody goes, the horror.
We should have waited. Right.
And also everything like this has a bad name forever, right? The next time this happens and we have to do this, they don't do it. They probably wouldn't anyway, but they even more won't do it next time.
So that's actually a good point to make here, which is that the biggest payoff, I think, from doing this isn't for this, it's as a practice for the next time when it matters even more. That is, we will eventually have even worse pandemics. And one of the biggest benefits of this pandemic is that we are forced to take this seriously and think through some of these things such that we will be more ready next time.
Did that answer your question as you wanted it, Oliver? Or is there any follow-ups you'd like to ask in more specifics?
I think that basically answered most of it. I think I would be interested in a like rough probability estimate or something like that, or something like just like an overall judgment. It's like, yep, I recognize that these like those are some downside risks. overall I think they're like sizable, or overall I think they're like not really worth exploring more, investing more, just like to get a sense of where currently marginal intellectual progress can be made on this topic.
I mean, I'm just focused on the factor of 3 to 30 you gain and reducing death rates. I mean, that can buy you a lot of risk. You should be willing to take a fair bit of risk to buy that.
Yeah, I think that the social/legal risks of whoever tries it are very high probability, especially if not done very carefully or / with official approvals. But I don't think that the downsides that I was talking about are very likely. I think it was just a matter of like what might go horribly wrong. And those are the things that I can imagine going truly horribly wrong with it. Or I think sometimes backfires that do reputational damage is not that unlikely either, but probably pretty big underdog relative to just not happening. The other question is like, how probable is it this, if we develop this plan B, it's going to work and be a good idea and actually like, et cetera. I think that in the scenario where we are stuck in some form of lockdown for 6+ months effectively, where we're doing real economic damage the whole time, the chances of a good idea is pretty high. Certainly more than 25%, quite possibly, more like half. I think there's a decent number of reasons why. That's assuming we could actually test it and then have a place where we could implement it without like just being told no, right? Like, I think the most likely scenario is that
I should mention it's a big world. There's over 100 nations out there.
Yeah, we might convince like Singapore.
And just getting some place in the world to try it would be a substantial gain from the point of view not just saving lives, but creating a precedent future.
Yeah, that's a fair point. Like, I certainly think that if we got anyone to implement it, if it was right, it would be a pretty big deal. Assuming if it worked out and proved to be a win. I think that the scenarios where it's a good idea potentially are an underdog versus the scenarios where it's not, where either it's all over too fast or we manage to control it. But I have very high uncertainty about all of that. And certainly I don't think any of these numbers should discourage people from like thinking about the problem, because like, again, if you think that the upside is as big as Robin thinks it is, and I think that's a reasonable thing to think it might be, even if I think it's somewhat lower, it's still pretty big. And you think that you have a chance to move that lever somewhat, then unless you have a better idea, if you want to do something relevant to the situation, it's a reasonable thing to work on from a perspective of someone like us. That sound about right? Like, even if it's like likely not going to work. A better question is like, how do you make it likely to like get its chance, right? Like, how do we make sure that like if it does work, that we tried it?
All right, thank Ollie. Jacob is currently actually taking a while to get the next question in person. I'm curious. I think you said you had a second question. Is there something you want? Oh, no, I will retract that entirely. Thank you very much, and I'm going to kick you out of this call.
No more Oliver.
Remove.
It will.
Solid. All right, next question, enter. Hey, Daniel.
Hello.
Which country are you calling from? I'm going to guess Berkeley.
I would actually consider Berkeley to not be a country and say that I'm calling from the United States of America.
You win that one. What's your question?
My question is
right, but go ahead.
My question is, effective altruists up until recently spent a bunch of their time worrying about the world ending, or about saving however many animals from dying per year of factory farming, and all sorts of things. This disease, sort of, if you look at it, it seems like maybe a couple % of the world could die from it. That would be bad, but it doesn't seem like naively, it doesn't seem to be on the same scale as everybody in the world dying, or of other things that effective altruists typically worry about. So should we really be spending our time, thinking about this and, debating and such?
Thanks. Thoughts, guys?
Yes.
Yes or no question? Yes.
Maybe why is the
why.
question.
I was gonna. Yeah. You want to go first, Robin? Yeah.
Obviously, the trite answer is you should multiply the probability times the leverage you have. It's something you can do. This is right in front of you, and so it makes sense to even effective altruists shouldn't just focus on ending the world scenarios. They should look at the wide range of large versus small scenarios and look opportunistically where they can help. But certainly one of the biggest ending the world scenarios that people have focused on over the years is pandemics. And this is a pandemic. This isn't a world-ending pandemic, but the habits and approaches that are legitimized in this case and that are developed in this case will be the main resources we have if and when a really bigger one shows up. So it's well worth making this one go right just so we could be better prepared for a much bigger one.
And also, so other things to point out, one of which is I think this is more of an X risk or like approaching X risk than you're giving it credit for, in the sense that, for example, this could lead to a US-China war, which could be very, very bad. This could lead to lasting severe economic damage, which would be very, very bad, potentially even collapse of civil order under some scenarios. And if we don't get immunity for very long, this could be an actual civilizational threat. If this comes out every year and is this bad, because we can't shut down the economy like this every year. And if this thing goes, it's not good that we can sustain ourselves. So there are risks. But more than that, I would point out, X risk is a small percentage of what effective altruists worry about. Some of them worry about animals. Some of them worry about malaria nets and giving directly to poor people to make sure they can start small businesses. And those are two of the big networks, both of which get a lot more money than X risk, as far as my model is concerned. So I don't see why this is remotely inappropriate. And in fact, I have been very disappointed and puzzled by the failure of effective altruists to move a bunch of resources and money towards these problems when people in our community were very, very good about sounding the alarm that this was coming. We had a lot of opportunity, still have a lot of opportunity. And where is Open Phil?
I mean, I think Open
let
Phil
me briefly mention to listeners, please go to Less Wrong, and Jacob is pinging a bunch of you. Please refresh the page to check whether you have notifications. Sarah, what did you want to say, Dan? Was that, are you now convinced that folks should now be spending a bunch of time on the pandemic thing?
Kind of. I just wanted to say Open Phil really is funding some like forecasting work, and I don't know, they're not doing nothing. Was concrete.
So I wanted to mention that in most other areas of altruistic concerns, one of the big issues that come back again and again is governance. People have various ways they hope the world could be improved, then they face governance limits. Governance gets in the way, governance isn't there to solve the problem. We will be changing governance in response to this crisis. We already are changing governance in response to the crisis. How governance changes in response to this crisis will be crucial in terms of whether it opens it up or shuts down ways that we can coordinate on other important questions.
Yeah, I wanted to briefly add that we're currently finding out how good our institutions are at dealing with a pandemic. And a lot of people are currently quite surprised that the CDC is not preparing well enough and encouraging people to just do basic things in a timely enough fashion.
The CDC, the WHO, the FDA have all done really badly. Another thing before you get to that, I want to point out that a lot of EAs often talk about meta EA work, about raising the profile of and attractiveness of and status of EA to get more resources, to get more people working. And if EA proved instrumental in helping with this crisis, then that would be a tremendous boost to EA's profile and EA's ability to acquire resources and goodwill and so on. And so even if you didn't value the lives of the pandemic, I think you should still work on this.
Yeah, I would say that checking how good our governance institutions are is maybe we don't need to do it right now, but the raising EA's profile by helping out in a thing everyone wants help with, that seems pretty plausible.
Cool. Thank you very much, Daniel. I am now going to kick you out.
Okay. Goodbye.
Farewell. All right. Next question is still coming in a few minutes. Was there any other points you wanted to come back on? I guess I still was interested in trying to get your sense of the probability that the successful outcome here involves a herd immunity strategy that is greatly informed by doing a bunch of deliberate exposure versus the likelihood we will end up with a different sort of win condition that did not require a lot.
I say that you have to separate it out into conditional on the world stays otherwise unchanged and we find a way to give the world that option and they would take it if it was the right thing to do, versus what's the chance in practice that it happens. I think that second number is very, very low. I think that in practice, everybody hates it. we do not have that many resources, and we are unlikely to be able to make this happen. Not that we shouldn't try, but that conditional on it being right, it's still a large underdog, 10% or less to happen.
What is your answer to the first question? I'm trying to get
answer to the first question, right? So I'm very much less confident in that answer, but I would say maybe roughly 30% that we end up in a scenario where deliberate infection of non-trivial numbers of people is the right thing to do. And not just people in key specific positions, but a large percentage of the population would be the right thing to do if we could pull it off. I also worry that just our civilization, the same way it wasn't able to stop the pandemic in the first place, just doesn't have the coordination to pull this off.
Sorry, did you go for it, Robin?
Oh, I mean, the scenario that I find most likely and disturbing is that all the hope that's generated lately for a lot more testing and a lot more tracing and a lot more isolation, the same government agencies are going to be implementing that already implemented the failure before, and they just won't pull it off. And that'll consistently happen all through the West. And therefore, this will just get really big, and then it'll go back and reinfect even China and Korea, et cetera, who have been keeping it out until a much larger wave comes back to hit them. And then there will be this vast amount of death and all this finger pointing and all these recriminations and all this blaming. And, that's a pretty bad scenario, but it seems to me the most likely one. I'm happy to, support hope and to help the hopeful scenarios try to develop, but I still can't put a huge probability on them.
I think the reason I'm more hopeful than you are is because I don't see this as primarily resting on the government being competent, because I think that the people and the corporations and the non-governmental resources will pull this together and get us through this in a lot of scenarios, despite the government, right? Through the government's resistance. That's kind of a lot of what's happening already.
But in that scenario, we do a better counterfactually. We have a flatter peak than we otherwise would have, but still most people get infected and an awful lot of people die. Basically, you're cutting down the extra deaths that would have happened if everybody got sick in the same 2 weeks, because maybe now everybody gets sick in the same 2 months or 3 months, but still basically, and most everybody gets sick, and 0.5% of them die. And
I mean, when people isolate, mostly the government can tell them to isolate, and it seems to be pretty bad at forcing them to isolate when they don't want to. But it has the persuasive ability of just the media and the people and whatever has in fact convinced a large number of people to isolate, and that number will go up. And I do think the people who isolate will be mostly safe.
I mean, they'll be safe for a few months, but
yes,
that's not the same as safe. If a vaccine takes 2 years or 5 years to come, I don't see how they're safe for 5 years.
I mean, I think I agree that 5 years is a long time, but
2 years. I don't see how you can keep them safe for 2 years. People,
I think you get
all these people with even yourself isolated research, 2 years of staying isolated, the whole economy adjusting to isolation, that is a really tall bar.
I mean, so when we talk about testing capabilities, right? That's a key part of this. I see the government's role in testing as not stopping it from happening, as what they have to do. The government doesn't create tests.
Okay, but in equilibrium, on average, how often is each person tested? Do you imagine?
So,
Once
imagine.
a week? I mean, come on.
I think maybe
once
more.
a year, maybe.
I think with pools, maybe a lot more than that.
All right, I am gonna.
Good question.
The people coming on is kind of slow, so I'm going to ask a few questions that people submitted, and then if anyone else joins in, we'll add them. But otherwise, hopefully, we'll have it more streamlined for next time.
Yeah.
So I've been sent a few comments. So someone has said, I think we are unlikely to hit herd immunity levels of infection in the US in the next 2 years. I would like to see Robin and Zvi discuss whether they also think that or not, since this bears on the value of Robin's proposal and lots of other things.
Well, that's what we were just talking about. How plausible is it that people can just stay isolated for the next 2 years? A majority of the population stay isolated enough for the next 2 years not to catch this.
Right. I mean, the scenario that I think is most likely is that a significant number of people get infected, but not enough to achieve herd immunity if we completely returned to previous activities, that people still, attended their sporting events and their weddings and their buffets and so on at the same frequency as before and shook hands all the time and so on. but we will make a significant number of adjustments on those levels, probably including getting behind wearing masks. I think that's probably a few weeks away at most at this point. Seems like people have gotten over their initial wearing masks makes you a pariah thing. And together with a lot of people in potential super spreader positions being immune because they already got infected, and people taking various degrees of precautions, I think we can get R zero below 1. And then it's not that hard to contain outbreaks as they happen. I still, I think that's
that just seems to me a crazily ambitious scenario. I mean, I'm just very impressed by how complicated the world is, how uncoordinated the world is.
Right. The reason why I'm confident in it is because I don't see it as having to check off the following 6 boxes. I see it as a mathematical formula where you have to do enough things to get below 1.
So say some places are below 1 and others are above 1. Unfortunately, the nature of exponential weighting is that even if 85% of things are below 1 and 15% are above, on average, you still have growth. So it's that last percent of the deviance really put most of the weight because this is an exponential growing thing. So it's not enough that half the places are not below 1. That doesn't do it.
All right, let me jump in and ask one more question I think we're going to get another audio person. Someone's asking, as an authoritarian country with not much consideration for medical ethics, China is able to try the deliberate infection route. They also have plenty of medical expertise, so this idea was probably considered. Furthermore, if it was successful, I would expect them to announce that, or at least for the information to be leaked. Is there a plausible story here for why we haven't heard about it yet?
Well, I mean, they're humans with the same sort of human reluctance to consider various scenarios as we are. So the average Chinese isn't that different from the average person of us. It's more, does their structure select out and generate it more than ours might? So I could believe that somebody in the Chinese government has generated this option. There's a white paper or something that's submitted to some higher level sitting on somebody's desk. But then I presume the reaction above is, well, at the moment we've locked this down. This isn't, I would think the moment when they were considering that would be when they were facing a wave from across the shores where they were feeling like either we lock down our borders and then we're really hurting our economy, or we expose ourselves. And that's the moment when they would consider deliberate infection. So then, but they, like us, probably would find it, looks bad PR to talk about it. So they would probably be privately setting it up as an option to consider, but not publicly talking about it, because if they weren't going to do it soon.
They have less barriers in some ways, but definitely not no barriers. And I think they'd have to consider whether or not trying to do this would already be a disaster for them. Because I think my model of Chinese.
Their story is they beat it, right? Their story is they fought it and they beat it. So they have to give up on that story to go with deliberate infection. At some point, they may well do that, but they don't want to do that now. They like this story.
The story came out 2 days ago that the Chinese movie theaters got shut down, and a lot of people were like, "Oh my God, maybe China is just lying about everything, and actually things are terrible." And there's a story about urns in Wuhan that implies maybe there were 46,000 deaths. And
all right, let me introduce another guest. You may have a sense of who this person is. Hello, is Alyssa there?
I've never seen this woman in my life. The story came out 2 days ago that the Chinese movie theaters got shut down, and a lot of people were like, "Oh my God, maybe China is just lying about everything."
I currently hear Zvi.
Terrible. And the story got on a delay. Yes.
Cool.
Zvi, I'm currently hearing 2 of you. Is the thing pre-recorded?
No, the YouTube video is 20 seconds behind. Just pause that one while you're chatting. Cool. Alyssa, do you have a question you want to ask?
Yeah, so is this on now?
Yeah, you're on. It's
cool.
Good.
So Zvi, you wrote in your moral mazes sequence about the impact that negative shocks have on society, and how in past social equilibria, negative shocks were important and in some sense necessary to stop institutions from becoming sufficiently bad. Obviously, this is a large negative shock. Various people have said that it's the biggest shock to the world or Western civilization since World War II. Last month, various people were pontificating about how, this might be the end of the Chinese regime. now various people are pontificating about how it might be the end of the West. If people can switch their stories so frequently and not explain why the previous story was wrong, I'm not sure I trust them very much. Do you have any like specific thoughts on like, how this particular negative shock will like impact, the particular institutions that we have? Like how this is an example of like the previous theory?
Right. So the thing I was saying when I got sort of cut off was that the Chinese might not be considering deliberate infection because they think that if it was so bad they needed to do deliberate infection that their regime would end regardless of what they did. So why plan for it? I think sometimes authoritarians sort of do things like that. Well, if it's that bad, we just have to like suppress it even harder / like pretend it doesn't exist and hope for the best. But I just don't have that great a model of China. In terms of what might happen, like a lot of companies are going to fail. That much is very obvious, right? A lot of small businesses will fail. A lot of big businesses will almost certainly also fail. The bailouts are not that big and won't save them if they're inherently unprofitable in any way. And others will take their place. And a lot of that could be very good. And there'll be a lot of degradation of trust in a lot of major institutions because they lied their asses off to us and proved themselves incompetent. And in some ways that's bad, but in most ways, in the long run, that's very good. And in general, it could be seen as creative destruction, the equivalent of urban renewal, just like a bunch of stuff got torn down. And it's sad that a lot of people died, and sad that a lot of people are broke and don't have money. But when things come roaring back, there's an opportunity to do more innovation and change. Obviously, we'll be much more receptive to doing things remotely in various ways. Zoom is up 8x, not just because they think they'll make money in the next 3 months, but because once people start doing Zoom, they'll realize we can talk like this. And then maybe they'll keep doing it. I think that like the predictions of the universities dying are plausible because it's a lot of money to pay for something. If you learn, you can get it somewhere else. And similarly, like a lot of people realize that schools were a terrible idea when they don't have them for a while, I'm guessing.
Do you think universities and schools will be, summer vacation or what would have been summer vacation is coming up for 2 months. Do you think everything will be shut down past then?
Yes, I think certainly there's almost no chance they'll reopen this semester. Mm-hmm. I think that is basically null. Like, or if they do, they'll be like, I think Liberty University reopened because they're insane.
The question is August.
Yeah, August. I think there's a decent chance they can open in August. But there's also a decent chance that a lot of people don't want to come even if they try to open in August, mm-hmm. because they've learned they can. Like the issue is not like people have summer breaks all the time, but when you actually try to learn from home, you realize that, a huge percentage of what I did in college was a mix of like opportunities for socialization I didn't use because I was an, introvert nerd, and reading books, right? And working through problems. And I can do that at home. I
think I disagree with this one with Z probably more than anything else in this entire thing. I think universities are going to do just fine. Okay. People will realize they missed their friends and hanging out with other people at school, and they will want to come back and do it. The kids don't like staying at home and not seeing the other kids. They want to be with other kids. But that.
Okay. I know. I hated school, so maybe that's biasing a lot of my perspective.
Oh, kids hate school, but they love to be with the other students. They want to hate school together. They hate to hate school alone. Yeah, it seems like you should be able to goal factor this though. Like very effectively. College is very expensive. So I was going to make the comment about like, we like to think that we're going to collect evidence here and then we'll find out better ways of doing things. But one of the big things that's going to happen is people will be desperate to construct stories about who wins and who loses and who is right and who is wrong through this whole thing. And those stories don't have to be accurate. And there'll be a lot of collateral damage from the stories that win, crushing some true things that aren't convenient. So even if, for example, deliberate infection showed that it worked, if the best story that came out that one didn't like that, it might well say it was bad. And if you just look at history of past crises and see what actually happened versus the stories people tell afterwards, it's not that strong a correlation.
So there's also just some other economic impacts. I expect VIX to be permanently higher. I expect options, like long options, to be permanently more expensive, or at least for a decade or two. I expect companies.
The volatility index.
What?
VIX
the volatility volatility index, like the people's predictions, to be higher. I expect people like options that are well out of the money to be more expensive for at least a decade, probably longer. I expect companies to be much more cognizant of their supply chains and like how to work from home and what would happen in the event something similar like this happens again. In general, I expect people to be to actually prepare for such a thing. Like they'll prepare for the last war, even if they don't prepare for the next one. Right?
Yeah.
Yeah. So there'll be a lot of that, and probably a lot less international trade
And travel.
and travel. Yeah.
Okay, Alyssa, is that a solid answer, or is there anything in particular you wanted to put back on?
I mean, you could go on forever, but that was great. Thank you.
Yeah. All right.
Yes, we could go on forever, and that's all we had for you. Cool. All right, thanks a lot, Alyssa. I'm gonna. There we go. All right, I'll invite the next questioner in, and then probably this will be the last question, and we'll wrap up. All right, all I have down for this person is Lotus Cobra, which, if it's a name, is awesome. Hey, are you there?
3, 2, 1.
Hi, I can't hear you so well.
Try playing a land.
Sorry, hi, can you hear me now?
Yeah, I can hear you
Yes.
solid. Well,
Fantastic.
Feel free to say who you are and where you're from, insofar as you would like to give identifying information.
All right, well, my name is, I am Lotus Cobra. Some people might know me as Barfight. I'm calling in from Canada right now. And I've been following Less Wrong for about 10 years now, but I created an account like 20 minutes ago just to ask this question.
Wow, it's a momentous occasion.
Right.
Please tell us
Yes, I
awesome
felt
question.
like this warranted it.
Cool.
And like Alyssa, I had to dig out an old computer to get this running, so I couldn't get the video working. Sorry, this isn't a privacy thing. I literally couldn't turn the camera on.
No worries. It's totally cool. So what's your question?
All right, so my question is this one's more for Robin, although everyone feel free to join in. The deliberate exposure plan has evolved pretty substantially since it first came out in the middle of February. But right now, what advantage or like what information do you expect to gain from deliberately infecting, say, 10,000 people with COVID-19 that we're not going to get from longitudinal studies, the natural experiments you were talking about earlier? And do you think this information is going to be worth all of the risks that we've gone over so far, the reputational risks potentially, but also the worst case scenarios, like what if infection does not provide protection in the future, that kind of thing?
Cool, thanks. Robin, what are the main benefits?
So, I mean, if you're talking the cost, if you do 10,000 people, then the 0.5% mortality means you're talking 50 people, right? So right there, if you screw it up, you will have killed more or less than the 50 people than you could have. So that's a huge personal responsibility to take no matter what. But of course,
If they're all 23, you can kill 1 or 2.
right, exactly. So which case is more of a problem? You need a bigger experiment with younger people to see what affects the mortality rate, although you can track other symptoms. The main thing you hope to gain, there's 2 main things you hope to gain. You want to know specifically how to produce a low dose infection reliably. You want to know like how to take the original infectious virus, how to store it, how to transform it, how to infect, deliver it to the body, how to do that reliably, and what the dose is that puts you in the right range of most people get infected, but they're not infected very much. And then how can you tell? So the other sorts of data is just not going to tell you that. It would take a long time with other sorts of longitudinal data to get you that sort of data about exactly how to infect people so that they have a low dose.
Cool.
And the other thing you would get, which is perhaps even more important, is most of the world just does not believe abstract arguments. Most of the world needs to see a concrete demonstration of something before they're going to take it seriously. If we actually had it happening at an actual facility, even with only 100 people at a time, you'd have newspaper articles about it. You'd have people talking about it. They could imagine it happening, and then they could debate whether that was a good idea in a far more involved way than they would if we just have abstract blog posts. That would probably be the main benefit, is just to say, look, this is concrete and it's real, and it's the sort of thing you could do.
Cool, thanks. Lotus, is that a solid, do you feel that was an answer to your question?
Yeah, I think it does. I don't really have any other questions except to say that, except to thank the both of you for coming out. Take care.
Thank you.
Cool, thanks, Lotus. I'm going to set you out of the room now. Thanks a lot. Yes, thank you for coming out, and by coming out we mean sitting in your homes and not leaving in any remote way. All right, I'm going to invite the last questioner who is on the call, which is Miss Elizabeth Van Nostrand. Hey, Elizabeth, are you there?
Yep.
Yo, what's your question?
So I don't have a sense of what scale Robin is talking about deliberately infecting people on. Is it like we do a couple of brave volunteers and they staff things? Is it we gradually do half the population?
Right. So, I mean, that's exactly, in a sense, one of the main problems with trying to make proposals, policy proposals, is that that distinction gets muddled up. The simplest thing to talk about is the thing that would ultimately happen. But if you're trying to talk about the thing that would ultimately happen, people immediately respond with, but look at all the uncertainties. How could you possibly know how to do that right? And of course, what you really want to propose is that you start down a path that could get to that big thing, but that along that path, you would be doing small things that would be telling you all the key things you need to know about how to do the big thing right, or even whether to quit and don't do the big thing.
Okay.
So I am talking about both. I mean, we can't talk about the short things without talking about the big things too, because that the whole point of doing the small things is to prepare for and to lay the groundwork for the big things. But it's stupid to just pretend like we could know exactly how to do the big things right out from the bat. So in any policy area, you know, including this is for all policy whatsoever, you're always talking at these two different levels of trying to imagine the thing you'd eventually do and how that would play out and whether that was a good idea. And then trying to think about what path you would use to get there in terms of what experiments you do, what permission you ask for, what trials you do, and what variations, so that you could learn not only how to do it right, but also create demonstrations and motivation and excitement and energy and attention such that you might eventually get to the big things.
So are there things where in the small, if we ran a couple of small experiments that would convince you we shouldn't continue?
Well, sure. Like neighbors come with shotguns and shoot everybody because they're really offended by the whole thing. I mean, it means you don't do it that way. You have to go much more isolated, for example. Obviously, if you think you know how to, you know, if it turns out there's some really strange effect where you modify the virus in a way you thought was harmless and irrelevant, but it turns out to make it much more harmful and a lot more people die. Now you go, well, I guess I didn't really understand this at all, right? So, for example, I know that one way in experiments in the past that people have used to infect people with, say, the flu is just play cards. You have somebody with the flu and a bunch of other people without the flu, and they play cards together. And you know what? People catch the flu. So that is a mechanism of deliberate infection. So it's just showing you there is a lot of very straightforward mechanisms, but you could pick some cleverer mechanism that you thought was clever and that you were wrong. You mix it with lemon juice. You don't think lemon juice matters, but somehow, you know, it does.
Okay, so Robin, so I hear you saying like before you do the big things, you should like do smaller scale tests. But in the world where it is like the plan B and like deliberate infection is like the primary like solution mechanism. I'm curious what your mainline like expectation is for the like rough percentage of like, I don't know, the US population or something you expect should be deliberately infected.
Well, I mean, since like the natural R naught of this thing is what, like, you know, 4 or something, then you can calculate from that the percentage of the population you need to be infected in order to get herd immunity, which is like 80% or something, 70% or 80%. Yeah. So that's the number of people you need to be infected one way or the other. And once it works, you might as well use it in the sense that, like with smallpox, there was no like infect some people with the smallpox thing variation and other people another way. They were trying to get it to enough people so that you know, basically they stop it.
So I will point out that I don't think it's as simple as infecting 80%. I think the different people matter a lot more or less than each other, and like et cetera, and you can do very different things. But yeah, we're almost out of time, so I won't.
But on the order of half the population.
Yeah, I think on the order of half. Yeah, minus whoever's already infected.
Right. And so the longer you wait, the less opportunity you'll have to infect the other people who could have had a, you know, much smaller reaction to, because they could have had a much smaller version.
All right, Elizabeth, was there any follow-up you wanted on that, or is
Good,
cool? Thanks a lot. I'm gonna take you out of the room. Yep, cool. All right, I think that's a wrap. This was go on.
I'd like to thank my co-debater for being reasonable and intelligent and thoughtful. And I'm pretty sure if I debate anybody else on this topic in the next month, it will be a much more hostile engagement.
And I will have hostile, yes.
Yeah, no, thanks. This has been Matt. I think I asked you both to do this on Monday or something insane. So thanks a lot for getting available quickly. Appreciate a bunch of people, like 100 people have been watching throughout most of this. So that's, yeah, no, this is quite exciting. Yeah, I know. This has been quite cool. So next, there is an online meetup that you can join. We are going to try the open source sort of VR platform Mozilla Hubs. You're welcome to find it on Less Wrong. There's a link to a bunch of rooms you can join. I assign some probability to this being awesome and some probability to this not working out at all. And we will, in about 20, 25 minutes, we'll have a good sense of that, and we will put up a link to a Discord server instead if it seems to not be working. But I am going to be heading into the Mozilla Hubs chat rooms, and I expect I will chat with a bunch of you guys there. Is there anything else I wanted to say before this thing wrapped up? I had the one thing I forgot to say at the beginning, which was another thing that's inspiring wanting debates for a while, was there was an amazing, one of, I think, Ollie's favorite Wikipedia pages is the Wikipedia page for the Scientific Revolution. And at the end of one of the sentences there's sort of a lead-off sentence, and it has no citations and no links and no further explanation. And it just says, and there were many philosophical battles. And that's been going around our head for a while, and why I wanted to like start having a bunch of debates. And this was just quite fun. So thanks both for joining. And I have a good time quarantining in your homes over the next couple of months. I'll see you again.
That is the plan. So
yeah, cool. All right.
Yeah, bye.
Thanks a lot. Farewell.
Right.